Room 9, we will be thinking through what whole person care is in terms of the call that God has given us as healthcare workers. And to help us begin this discussion are two friends of mine. One is Robert Sadler. Robert Sadler is a family physician, though retired now. He lives in England with his family, and he is the chair of the management committee for Prime. Prime is a partnership for medical education international. You will be talking more about that in a while. And they are together with Paul Rillians, who is a general and renal medicine at the Wolverhampton town, which is the hometown of Wolverhampton Wanderers, the football club. He's a professor at the University of Birmingham, and together they will just help us go through what whole person care is. Welcome, Rob.
Thank you, Daniel. Lovely to see you and everybody else. There aren't many of us, so that means we can be quite open and intimate with each other, and we want you to be able to feel free to contribute. Paul's going to introduce himself first. I'm going to say a little bit more about yourself, Paul.
Yes, I'm Paul Rylands. I'm a consultant in general and renal medicine at a big hospital in Wolverhampton, which is in the central part of England. I've been teaching postgraduate and undergraduate students all my career. And I've been a tutor with Rob in Prime, and I've been to Africa to teach whole person medicine there. So it's an absolute pleasure to be with you.
Thank you, Paul. So though I've retired as a family physician, I'm actually vaccinating against COVID at the moment. And so I'm still working a bit clinically, but spending a lot of time at the moment online, because the world has changed. And whereas Prime used to go and visit about 25 countries every year, taking about more than 100 tutors, now we're increasingly trying to adapt to being online and teaching online. So we're going to try to make this as interactive as possible. So I'm going to start with asking you all a question. It doesn't matter whether you've been qualified for 50 years or you're not even qualified yet. I'm asking a question which you can either sort of put on the chat or you can respond to verbally. And that question is very much in line with the theme of the conference. Why did you go into medicine? If you can think of a one sentence and put, why did you go into medicine? And put that down on the chat, or you can say it. Let's just see what responses we get. I'm going to start, and it is really true that a few months before I applied for medical school, I had no idea I was going to do medicine. I'd become a Christian, and all of a sudden my focus changed, and I just felt a conviction it was the right thing to do. Nobody in my family had done medicine. I wasn't pressurized. Nobody suggested I do it. I met a couple of doctors at an evening at school, and I felt increasingly convicted that's what I should do. And from there on, what's happened in my life wasn't so much under my control. It sort of happens without me making a lot of decisions, one thing on top of another. Yeah, I would say that I did want to encourage and look after people, care for people, but actually it was just a conviction in my heart that that's what I should do. Anybody else want to contribute? How about Herbert? Because you're a medical student, Herbert. This must be new to you.
Joined medicine. I've liked the profession even ever since I was young. So whenever I could look at a doctor, I was like, yeah, I want to be like this person. And also it went ahead when I reached my secondary school. So I found meaning to it. You know, when you walk in the streets and you see lots of sick people, many lame people on the streets, many people with different conditions, I was like, God should help me become a doctor. Maybe one day I can help one of these people. Yeah, that is it. Thank you.
Okay, so you actually saw somebody who was a doctor and you wanted to be like them, you said. Okay, there's Bhaskar's answer, though he's not medical, but he wanted to go into something which would affect people's lives rather than just line his pocket, rather than just look after himself. Anybody else want to contribute?
And perhaps
Okay.
I can also say that I originally was going to a laboratory job, microbiology, and it was my dentist that tried to persuade me out to be medically qualified. And so I actually only got accepted for medical school a month before I started. But a bit like Rob, I can see in retrospect that God was working through me. And I think sometimes God worked through me despite myself. And I am where I am because of God's hand in it.
Thank you, Paul. So one of the things that happens when you go into medical school, when you start training, is it's not always how you think it'll be. And especially in the beginning of your training, you find that you're introduced to anatomy and physiology and the body systems, and you get more and more knowledge about how we function as human beings. But when you actually go onto the ward or when you see patients, it's a bit different. Now we're going to do a role play, and Professor Paul's going to introduce it.
So I'm a doctor at a hospital or a clinic. I'm seeing Mr. Rob, who's my patient. So what I would like you to do as we do this role play is actually to think about what's going on in Mr. Rob's mind, what the things that are troubling him, and what we might have to discuss about him to try and solve his problems, and whether there's more to it than just his medical problem. Hello, I'm Dr. Paul. Thanks for coming to see me. What can I do to help? Rob, you're muted.
Sorry. So Professor Paul, thank you for talking to me. I don't feel any better. I still feel bad. I don't feel well at all. I did see somebody last week, and I just don't feel better at all. Right.
Yes, I see from our notes that that he saw you and you had the similar problems, and he gave you some antibiotics and vitamins. Why do you? What's the issue? Tell me a bit more about it.
Well, I still feel very, very tired, and I have headaches, and I don't feel good, and things all going wrong, and I don't know what to do about it. Right.
I mean, you've normally been a very fit and healthy man, but you don't look the same as you used to be.
No, I don't feel, no, it's not good. No.
Right. Well, I mean, obviously the treatment that the doctor gave you didn't work. So there's obviously something else going on. I mean, is there anything else going that you want me to tell you?
Well, it's very difficult. I didn't tell the other doctor. It's very difficult. It's something I'm really worrying about.
And what's that?
Well, it's nobody can find out what I'm saying, can they?
No, this is absolutely confidential. I can assure you that anything you say to me
you see,
stays in these rooms.
About 6 months ago, you see, I work a lot away from home. I'm a carpenter and I build, and I had to go to other towns. I worked at home, and I was feeling very lonely. And you understand, I do love my wife, but I went with this other woman. I know I shouldn't have done it. It was awful, and now I'm really worried.
And what are you worried about?
Well, you see, I just don't know. I'm feeling ill and I'm feeling unwell. I just wonder whether I've got something.
Right. Well, I'm certainly. I mean, we need to think whether you have a medical problem that we haven't got to the bottom of. But I mean, it does strike me that we have to be. We have to think whether there's any possibility you may have caught an illness. A sexually transmitted illness, and particularly, I think we have to screen you for HIV. I mean, that might be a shock to you.
I know you were going to say that. Oh dear, I don't know. See, my wife mustn't find out. I feel really bad, and my wife, she works with the church, and if they find out that it's not going to be good at all.
Right. Well, I think in these circumstances, the most important thing is for us to do a test on you to start with, and that's very simple and easy, and then we'll be in a better position to know where we stand.
But nobody else can find out, can they?
Well, certainly nobody will know about the test, but unfortunately, if you have had contact with your wife, then we might have to, if you turn out to be positive, then we're going to have to talk to her about doing the test.
No, you mustn't find out.
Okay, can we leave it there? So we have a man who has come twice with two problems. The problem's not been dealt with. He doesn't feel any better, and then we slowly get out of him that he has concerns about that he might have caught HIV, and he's thought about it. What do you think is going through Dr. Rob's mind at this stage? What are we going to have to consider over and above his medical condition? You can certainly put those on the chat line, or is there a few of them you can talk it out equally?
Shame and social stigma.
Absolutely, yes. I mean, why do you think he's going to have why is the shame particularly a problem?
I think shame would be a problem depending on the cultural context. Though men usually do tend to get off easily, contacting HIV means that he has been unfaithful. Men do tend to get off easily, but over here it will look like that he is still a foolish because he contracted it. So while the action of being unfaithful might not be judged that much culturally, but him getting the disease would be, and then everybody tend to kind of stay away, thinking that they may get impacted as well, and the whole family is also going to be impacted, I believe.
Absolutely, yes. I mean, he's it's going to be something which he's really very concerned about, and I think Herbert, you've got your hand up. Would you like to say something?
Yes, I would also say that apart from being shameful, he's also worried about the outcome of the test. That is why he's trying to hesitate on making the test.
Absolutely. So what we don't know is how much he understands about HIV. There's clearly a lot of anxiety and sometimes misinformation put around. And so we need to, at a certain stage, if he turn out to be positive, then we have to have discussions about the medical condition. I mean, Rob has said that he needs forgiveness. He's obviously very anxious about that. And who do you think he's going to need forgiveness from?
From the wife.
Absolutely. And that may be very, very difficult. I mean, he doesn't know how she's going to respond to this. We're talking about, later on, we're talking about compassion, and certainly compassion in this situation might be quite difficult.
And would we also say there is also that point of guilt?
Absolutely. And that, you know, guilt is something which can stay with people for a long time. So even if the test turns out to be negative, he may still have guilt about his behavior, and that may have an impact. At least he's been honest with the doctor, and that's very helpful, because sometimes we find it very difficult to get to the bottom of what his problem is. And so as a doctor, we may have to not only consider the medical problem, but how we can support him in that guilt, not necessarily ourselves, but actually pointing him in the direction of someone that might be able to help him.
So, can I ask a question? Is my need just medical? As a patient, is my need just medical?
Nope.
So what other need have I got?
Number one, as a believer, as a Christian doctor, you definitely know that this person has sinned, and it's good for you at that point being able to lead this person to Jesus Christ, if at all that would be the exact time that the person would receive Jesus Christ. And number two, we also have to consider the people, but as the people, like now the wife and the children and the society, and with regards to how the society is going to feel about this person, how the wife is going to see this person. Maybe there will be like some lost trust, but again, you have to like come in and try and reconcile every other issues.
Yeah, so it's a much bigger problem. In a sense, the medical problem's the easy bit, isn't it? That's the straightforward part. The difficult part is the problem with his spiritual need, as you said, for his own self, for his need for repentance and forgiveness for him, but also for forgiveness and restoration from others as well. Do we expect to be dealing with these problems when we get trained in medical school? I'm going to ask Herbert, because he's a student. Do you expect to be trained how to address these problems?
Nope.
No? Herbert, what about you?
That was Sheila, but I still also say no, because in the practice they will teach us how to address only the medical aspect of it, but this other spiritual and emotional aspect, I think it depends on the person that is treating, that is me, and how God will lead me to maybe work through that patient. Yeah,
absolutely. So what you're saying actually is interesting, because you need a spiritual reality in your life if you're going to help somebody else. That's what you've both said, isn't it, Sheila and Herbert? So you need something that you can give, which is beyond your medical training. Now, I'm just going to share my screen, and we're going to talk a little bit about why this matters so much. Can you see that?
Yes.
Yes.
Okay, so let's just set the scene a little bit spiritually here. So when Jesus taught, when he spoke to them, when he ministered to them, he brought more than just physical healing. He brought the kingdom of God into their lives. And in Luke 10, and we talked a lot about Luke 10, interestingly, in this conference, John Wyatt mentioned it, talking about the need to move into ministry And so Luke 10:8-9 is when Jesus asked the 70 to minister, to go out and minister to people. And in the same way, he calls us to minister, as we know as Christians, whether in our organization, our workplace, or in our home or our church. And when Jesus was ministering, he had the amazing ability to see the whole person in front of him. He didn't just look at the presenting problem, which is what we do as doctors. He looked at them as a person. He looked at their life. He understood where they were coming from. He probably understood and saw the sort of life they had and the problems they've had and the condition they were in. And so when Jesus ministered them, he ministered to the whole person, not just to the presenting need. The problem is, as doctors, that in our workplace, in our training, in what we do from day to day, it's very easy to become increasingly linked to just performing one set of tasks. It may be one specialism, it may be one method, it may be one way of practicing, okay? And it's quite true, and somebody mentioned it yesterday, I think it might have been Peter Saunders, mentioned it yesterday, that no, it was Rick Paul, who said that when medical students and doctors initially start their training, they are motivated by care and compassion, but they then become motivated by other things, by position, by power, by being increasingly promoted, and by money. And we lose touch, if we're not careful, with our initial calling from God, what he calls us into medicine for. So what we're going to try and do in the remaining time we have is to give an opportunity to see where we are and the importance of regaining the ground. In other words, trying to make sure that we are true to our calling and that we do, as Jesus did, minister to the whole person, both in our work and our home and our communities. So what is a whole person approach? The first thing is you see the person in front of you as a person and not a patient, or even worse, a disease. Okay? Everybody is unique. Everybody is different. You treat somebody the same way and they don't necessarily respond the same way. The reason that people present are very different. Some may present early, some may present late. Some may have a set of fears. They all have a set of beliefs about their health and about their lives. And therefore, they're an individual to be looked after and treated, not a condition, not a disease. This is William Osler. William Osler is described as one of the fathers of medicine and practiced in the late 1800s into the early 20th century. And he said this, he said a number of good things, but he said this: it's much more important to know what sort of a patient has a disease than what sort of a disease a patient has. I'm going to say that again. It's much more important to know what sort of a patient has a disease than what sort of a disease a patient has. In other words, knowing your patient is more important than knowing the disease. They're both important, okay, but knowing the patient is really important. And these knowledge of a patient is a combination, of we've just seen in the role play, of an understanding about their physical body, their physical state, their mind, and their spirit. The problem is that you can't, when you see somebody sitting in front of you, you can't unravel them and just treat them as a part. They are combined together, and we have a physical body, a spiritual body, and somewhere between the two is our mind, our intellect, our thoughts, our emotions, which together decide how we respond to situations, how we respond to illness, how we respond to fears. And it may be, if we've got something fairly straightforward like a broken bone, that we have more of a physical problem, we have a disability, we have pain. Our minds will be concerned about that. We may be fearful about how we're going to survive, what's going to happen to us, and that will also affect our spirit. So it may be more of a physical problem, but it's going to affect the whole person. Equally, we may have what we think is more of a psychological condition like depression. But depression, as we know, not only affects the mind, but also affects the spirit. We feel worthless, we feel useless, our self-esteem goes down, but it can affect our physical body. We can become anorexic, we can become constipated, we can have headaches, we can have pains and aches. So whatever condition you care to look at is going to affect both body, mind, and spirit. The problem is they're all mixed up like this mosaic, this Roman mosaic. It's very difficult to untangle them as a doctor, and it takes a lot of time and skill. So Herbert, you've started off, keep going. You've got a lifetime to learn this, and we've all got a lifetime to learn this. The most important thing is that we understand from the outset that that is the problem, so that we make a holistic assessment of the needs the patient has, as Professor Paul was just about to do with me. And it doesn't necessarily mean that we have to meet all those needs ourselves, okay? But we can engage others. It may be the pastor, it may be the social worker, it may be a friend, it may be a colleague. So part of having a holistic assessment of the patient is also working with a team which supports each other and a team which has a good relationship with each other. Let's just go back to Jesus for a minute. Okay, so when Jesus sent these 70 out, and he said, when you enter a house, first say peace, shalom. Now, shalom, the Hebrew word shalom, does not just mean peace, as we translate it in English. It means well-being, wholeness, completeness to this house. So Jesus was effectively saying what we've just said. We want all to be well, body, mind, spirit, and then beyond that, the community within the house. And that's what you speak when you come, and indeed what we should speak when we see a patient is we wish for wholeness and to be a conduit of wholeness ourselves. Okay? He then says, heal the sick who are there and tell them the kingdom of God is near you. So when you see a patient, do you believe that you're bringing the kingdom of God near them? Because that's what Jesus is asking you and saying, not that he's telling you to do it, he's giving you the authority, the ability to be the kingdom of God in some way ministering to the patient. And this is a wonderful way. One of the biggest problems we have in medicine is separating our compartmentalizing our lives. I think it was Rick Paul who mentioned that as well. We have a sort of medical life, and we may have a church life, we may have a home life, and we don't bring them together. Here Jesus is saying, I want you to bring it all together. I want you to come together within yourself, so you can be the doctor, the physician, the health worker, or indeed whatever you are, and the Christian in one way to bring one ministry to the patient or the person, whoever it is. Who mentioned this? I think it was John Wyatt who mentioned this scripture earlier on in Matthew 25, when Jesus is talking about the judgment and separating the sheep from the goat. And he says to the sheep that you saw me. Jesus says, you saw me when I was hungry and you gave me food, thirsty, you gave me drink. I was in prison, you visited me. I was unclothed and you clothed me. And they said to you, when Lord, when did we see you like this? When did we see you hungry and thirsty? When did we see you a stranger, you needed shelter, invite you in? When did we give you clothes? When did we see you sick or in prison and visit you? And Jesus says, I tell you truly, whatever you did for the least of one of these brothers and sisters of mine, you did for me. So here is a wonderful description of whole person care. Jesus is saying this is our attitude to each other and to others, that we are Jesus to this person. We can treat this person as if they were Jesus when we see a patient, but we can also be Jesus to them. We can actually minister the kingdom of God to them at the same time. Okay? Because we are made in his image, we are part of his creation, and we are all called to be like him. What do you need? What do you need to be able to give whole person care? Well, you need to be concerned about the welfare of the patient. This is a picture taken after the earthquake in North Pakistan about 10 or 15 years ago. This is Dr. Mary, who's gone there as a relief doctor to try and help the sick and the injured after the earthquake. And this is just a picture. And I love the expression on the little boy's face or girl's face looking up. That picture says much more than you can say in words. And I think the point I want to make is this: Jesus didn't necessarily need to spend a long time with talking to somebody before ministering to them. Sometimes just a touch would minister to them. And we sometimes get concerned about being compassionate and caring towards our patients because it might take too long or it might take too much out of us. Sometimes you just need a look and a touch to convey Jesus's love to your patients and to those who you minister to. Right, I'm going to go over to you in a minute, but I'm going to ask a question. I'm going to show you a picture. Was this ever a reality in a hospital? Was it ever reality that people would minister like Jesus in a hospital? Well, hospitals in Africa have only been around for probably around about 120 years, 130 years. The hospitals in Europe have been around for a lot longer, and this is one. This is the Hospital Santa Maria de Scala in Siena, in Italy. And this hospital was founded about the 8th or 9th century, but this was built in the 13th century. So we're talking about 800 years ago, or nearly 800 years ago. And on the wall of this hospital have been painted some pictures of what happened in the hospital after it was opened. And this is a picture I want you to look at. I want you to look at it for a minute or two, and then I want you to tell me either in the chat or verbally what you see. I want you to see what's happening. I'll just give you a context for it. This hospital was built for poor people. Rich people were often looked after in their homes. It was built for people who were travelers and pilgrims, and it was built for those who couldn't afford to be looked after any other way. And this is probably a beggar who's been brought off the street. So, okay, look at it for a minute or two, and then start to perhaps just to write on the chat initially. Tell me what you see. I can't find the chat on my screen, Paul. Can you pick the chat up?
There's nothing yet.
If you don't want to put it on the chat, there's no right and wrong answers here, by the way. We don't believe in right and wrong answers.
The gentleman must have been cut.
So
at least he's bleeding from the right thigh.
He's received a wound on the right thigh. Lots of people say to me, well, why aren't they stopping the bleeding? Well, the bleeding seems to have stopped because there's no blood on the chair.
But there is the gentleman who is holding his feet and looking at his eyes.
Yeah. What's he doing?
Washing his feet must be.
He's washing his feet.
And wiping with the towel.
Towel. Anybody else? Why is he washing his feet? It seems a bit of a strange thing to do. He's got a wound here. If he went to any A&E in this country, I can promise you they wouldn't be washing his feet first.
He's making him feel accepted. And eye contact also it is a way of conveying that he's looking at me as a person, not as a patient.
Yeah.
That's
so he's I don't know if anybody's had their feet washed. People who have said it's an amazing feeling, somebody else washing your feet. We have a reflex, something called reflexology, which is all about pressure areas on the feet to make people feel better. However, he's also looking at him and he wants to try and get his attention. And look as one of what? Concern? one of engagement. And as you say, it's making him feel accepted. It's making him feel, because he's a beggar, he's probably going to feel pretty worthless. Anybody else want to say what's happening?
And also, if you look at this person, he looks to be hurt. He's almost naked, and I can see someone else that is trying to clothe him.
Yeah.
As this person is giving him the care. And if you look at the other people around, they are all empathetic. They have this compassion towards him. It's like they are sorry for what is happening, something like that.
Yeah, it's probably a picture taken soon after the hospital was opened, and it may be visits from the money for this hospital was donated by the richer people in the city. And it may be the officials, the local government officials who've come to see what's happening in the hospital. This man will almost certainly be a priest or a monk, and it's his job to minister to the patient. This one is also another one, and he's holding this, giving him some privacy, as you said.
And somebody on the chat has said that Martha has said that the patient is afraid, feeling of shame or worthless.
Yes.
You can see by his posture and the fact that he's crossing his arms, that and he's looking sort of quite desperately for help.
He's looking a bit desperate. He's looking at. Would you say he was looking worried? Anybody?
Certainly that the chat says that he feels afraid. He really probably doesn't know what's going on.
This man here, he's the surgeon, and he's just about to stitch this wound up, and he can't wait to get at this wound. Okay. And I'll finish the story for time, because I'm going to hand over to Professor Paul. But in those days, they had no local anaesthetic, and this man wanted to stitch the wound up. So by relaxing him, by making him feel accepted, what happens to his pain threshold? It goes up.
I believe that will increase.
It'll increase. Yeah. He's going to feel, the more worried and anxious he is, the more pain he'll feel, the more accepted, loved, and relaxed he feels, the less pain he'll feel when the surgeon stitches the wound up. There's another picture of him being clothed. He was fed, given a meal, clothed, and then at the end of the session, he probably felt a lot better than when he went in. And that's a demonstration of whole person care.
You might also comment that the patient in the left-hand side who's looking very ill and is possibly dying, but there's somebody there caring for them and carrying them in a very sort of compassionate and gentle way.
Okay, so I'm going to hand over to Professor Paul, who's going to talk about not the fact that this is just good from the perspective of it's what Jesus calls us to, but also give us some evidence of why else it's good. Thank you, Paul.
So if I can just share my screen. Can everybody see my screen?
Yeah, we are seeing.
Thank you. So we've talked about the reason why we ought to be considering the whole person, and particularly the need for compassion. But we'd just like to think now about, what are the benefits? They're very good principles, but can we actually show some definite benefits? So what this picture is of a very sick child who unfortunately may not survive. We have responsibilities to that child for his or her medical needs. But look at the father. The father has a look of despondency, of resignation, perhaps. He's really profoundly worried about his child, but probably doesn't know what to do. So we have responsibilities, not just to the child medically, but also responsibilities to him as well, and perhaps his family. So we're talking about holistic care, where we do look at the disease, we consider psychological and social issues, but we might also consider the faith of the people that we're dealing with. And this, in whole person medicine terms, is dealing not only with the body, but the mind and the spirit. So what is the evidence base for this approach to treating patients? So firstly, what's the evidence base for disease management? This is the biomedical approach. Well, as Christians, we have an obligation, I think, to provide the best clinical care for our patients. That obviously is within the capabilities of our healthcare systems. And there are national and international guidelines and recommendations to how we should treat the patient. And I think it's absolutely important that we follow these. But the World Health Organization about 20 years ago pointed out that this mechanistic view of patients focused on medicine and surgery is no longer satisfactory. Patients and physicians have begun to realize that the values of elements such as faith, hope, and compassion in the healing process. And indeed, more recently, they put together an international guideline, a framework for integrated, people-centered health services. And what they did, analyzing the literature, they noted that there were benefits to the individuals of patients and their families of this whole person care. It's better coordinated care. It's shared decision-making between the patient and the professionals. It helps people understand about their conditions and their decisions they're going to make to promote more independence in those decisions. That patients can then self-manage their patients and helps in the control of long-term health conditions. And indeed, it leads to increased satisfaction with care and better relationships with the care providers. So is there evidence for the psychological and social supports benefiting the patients? Well, if we look at this study from Scandinavia that looked at the relationship of hopelessness and what the outcomes are of conditions, and you see from the patients that had a high level of hopelessness, their survival was worse, whether it be for myocardial infarction or for cancer. And this is looking at all the other factors. So we need to be aware of people's understanding of their psychological and social situation. And if we look at people with metastatic breast cancer, if they have no psychosocial support, then their survival is about 18 months. However, if they're given additional support to them in terms of their psychology, then it almost doubles their survival. So this is impressive data. And a more recent meta-analysis of the literature shows there was significant survival benefit of psychosocial interventions in cancer patients when measured at 1 or 2 years. So I think this is fairly challenging. So this was taken by an organization in Britain called the Health Foundation. And what they pointed out is that there are 4 principles of person-centered care or whole person care. It should be personalized to the individual. It should be coordinated with other health professionals. And this is enabling. And it's important that the person is treated with dignity, compassion, and respect. So they again looked to the literature, and what they found was that it allowed improved clinical outcomes. Patients were less likely to use emergency services at the hospital. They were more likely to stick to their treatment plans and take their medicines correctly. These are very positive things. The patients are more satisfied with their care. And interestingly, they may choose treatments based on their values and preferences rather than what the doctors think. And this is often treatment which is less invasive and less costly. So that's benefit to the healthcare in general. It reduces their length of stay and reduces the number of complaints. And what's interesting, it also helps the healthcare professionals, because as the patient engagement increases, the staff performance and the morale of the healthcare professionals also improves. But interestingly, if you look at a very medical problem, such as urinary tract infection, the symptoms were less severe and of shorter duration when the doctor took a more positive approach to the diagnosis and prognosis. And that's about communication. It's about being caring and about being compassionate. So that's not just to the patients, but what about the doctors? Well, if a compassionate approach is taken, then it's been shown that empathetic doctors have least risk of burnout. As there are better patient outcomes, the doctors can spend more time relieving the suffering of patients. And it's been shown that doctors, if they're compassionate themselves, have better immune functioning. So in a very recent paper in the British Medical Journal, it says that caring consultations require the doctor to be fully present emotionally and mentally, and for the patient and the doctor to feel safe. So this is a real challenge for us. So what is the evidence base for spiritual support? So this was a study where chaplains went to see orthopedic patients who'd had trauma injuries, and some received a visit from the pastor and some didn't have any visits. Those who had the pastor's attention had a shorter length of stay. They needed less analgesia. They required less of nursing time and had less pain and stress. So the chaplain would be caring for them, but may also have the opportunity to have discussions about their faith. This study from the United States looked at American adults, and there was a correlation between death rates and religious activity. And what was fascinating, that regular church attendance was associated with increased life expectancy of 7 years. And this was even more dramatic in the Black American population, where they lived for, on average, 14 years more. Now, we can discuss why that might be, but I think this is a marvelous challenge to take note of patients' spiritual needs. And this review article looked at the link between religious and spiritual beliefs and their medical conditions, and it showed they lived longer. They had less interleukin-6 elevation, that's inflammatory markers that cause disease. In advanced cancer patients, they were more satisfied with their life, they were happier, and they had less pain. And even interestingly, in heart transplants, they had improved physical functioning, higher self-esteem, and less anxiety and worry. The Association of Medical Colleges was sufficiently impressed by the data in the literature to recommend there should be a curriculum on spirituality. And they stated that spirituality is recognized as a factor that contributes to health in many people. Now, there are a number of aspects of spirituality, but it does include religion and belief in God. And they said that all these factors can influence how patients and healthcare professionals perceive health and illness and how they interact with one another. So do we have an element of spirituality in our teaching, whether it be undergraduate or postgraduate, or to our nursing and professions allied to medicine? So is this a doctor's business? In a survey, 75% of patients thought the physician should consider their spiritual needs. The problem was that 80% of doctors never or rarely discuss spiritual issues with their patients. So I put it to you, should we consider this to be necessary as part of all health workers' roles? In the last few months and the last year, we've had some difficult times, and to a large extent, it's been related to COVID. And the huge pressures of COVID are having their impact on staff, as well as, needless to say, patients. So how are the patients being treated when they have healthcare workers that are struggling themselves? how do we continue having compassion when we're faced with the intensity of our medical responsibilities without burning out at the end of it? So it's worth thinking about where we ourselves get our support. And it might be family, it might be friends, it might be our faith, our relationship with God and Jesus. But also it may be fellowship with our other Christian friends, which might be really important to keep us going when things are really becoming quite difficult, so that we can continue giving compassion. We can be role models. We are role models. And as Rob said, we look to Jesus as a role model for compassion and healing. And then we can reflect Jesus in our medical roles. And this can be irrespective of the faith background of the patients that we're dealing with. And what's important also is that we can be role models ourselves for compassionate care in our colleagues, in the hope that it will spread to everyone we work with, and it must be a priority for our healthcare. So I hope I've able to convince you that there is evidence for the benefits of whole person care, looking at not just the body, treating the body and the condition, but also thinking about the mind and the spirit of the patients. Thank you. If any of you are interested, there is those are the links for the Prime organisation, various ways you can contact the Prime organisation. And if you're interested in the work of Prime, you can also join as a Prime network member and be in touch with what we're doing.